So I'm sure you can all see my screen now. I've changed it to something a little bit more focused on, and I am just having a little bit of issues with my bandwidth. So I'm just gonna pop off my camera, just for the interest of you, my audio being audible. So what I'm going to be doing now is I'm just going to do a quick little pivot from talking about the toolkit itself, but then trying to make sense of how we can go about taking this toolkit and actually implementing it into the systems that we're trying to actually strengthen. Now, the first thing I just want to say is that if we have all of these tools available and we are not very deliberate about how we go about implementing them and monitoring the implementation, we might not actually see the effects that was seen by the facility-based toolkits, where we saw close on a half reduction in outcome, or in poor outcome, really. So my view on the approach to implementation really lives in 4 parts. The first is to create the conditions in which the implementation can succeed. So creating the enabling governance and environment for these to be taken up and to be implemented sustainably. Then we have to move into something around which tools do we implement when. Here we have to maybe do a little bit of triage, seeing what are the things that might be most impactful based on how a particular service and system has already developed. Then we need to find some way of thinking about how we can create an implementation roadmap so that we really can have these nice steps that we can follow, so that we can go ahead and see kind of where we're going, and ensuring that it's properly supported and properly financed and resourced to be able to ensure that this implementation is successful. And then lastly is about getting back to what the impact of these actual tools were. And eventually these 4 things cycle back into itself to move the evidence base into seeing how we can now reprioritize the next step. And in this way, we can have cyclical improvement across our entire system for a period of time. So I'm going to be just unpacking ever so briefly each of these different 4 steps that I think we can really think about and think through when we're going to be implementing this pre-hospital toolkit. So the first thing I want to say is that every toolkit and each of the different components needs to have a particular owner that is able to oversee its implementation. And when you study the toolkit, and both in terms of Pete and in terms of the operational guidance document, you will see that consistently there are these components and there's a call for governance and oversight, and a call for some champions to lead it. So if you think about the operational standards, it needs an emergency care systems regulatory authority that has the power to certify, accredit, and audit operational standards. Because the standard that's implemented, that's not audited, will probably not be implemented. And if it is implemented, we don't actually know to what extent it is implemented. And then our data might not actually support improved outcome. The same with the clinical protocols. It requires the medical oversight or director with a legal mandate to set and revise the scope of practice. Now, this could be system or single service-based, or this can be like a national regulator, but it requires these kinds of things in place. The same thing, the designated authority needs to be able to coordinate across multiple health infrastructures when it comes to medical dispatch and control. And in this case, it is quite important to think about where your regulatory authority sits, because in pre-hospital emergency care, there are multiple different agencies that are involved in one single response many times. So being able to coordinate across those different systems and services and frameworks would be really important. and so on and so forth. So you can see that all of these different things that we're hoping to implement in order to improve outcome in the end and improve efficiency of the emergency care system and pre-hospital emergency care really requires oversight first. If we think specifically about the enabling governance and policy positions that we require, we can see directly how PEAT itself actually has actually talks about all of these regulatory frameworks and enabling governance and policy structures that needs to be put in place. So I'm thinking about things like having the central authority, having financial protection to make sure that people can access emergency care, even if they cannot pay for it, having legal protections for bystanders to ensure that they are not criminally or civilly prosecuted should they help someone who might have been injured or ill. Thinking about things like enshrining in the Constitution that everyone has a right to emergency care, talking about leadership and how we can ensure that there's people who have oversight of training, oversight of supply chain, fleet. All of those elements are really important to ensure that the functioning of an of a pre-hospital service actually is able to be supported. And similarly, the regulations need to support toll-free universal access numbers so that we can ensure that even when those are in place, that they can be sustainably managed and sustainably supported. So at a minimum, taking through all of these, especially looking at PEAT and also what the operational guidance is demonstrating, there's a couple of things that if you were to create an enabling governance environment, these would be the legislative minimums that we would want to see in a system. And these are just things that I'm pulling out. This is not necessarily an exhaustive list of things, but these certainly give you an idea of what are some of the directions that we should be going in. So firstly, it's really establishing the pre-hospital emergency care systems authority that is able to look after the entire system. And most of the time, we actually prefer for this regulatory authority or recommend that this regulatory authority actually sits within the Ministry of Health to ensure that EMS is not simply an add-on to other services like in the Ministry of Interior or something like that, but is actually integral into the Ministry of Health, and in that way also that there is perhaps line budgeting for EMS itself, and to ensure that there's not fragmentation in the way that EMS gets thought about and included and integrated into the rest of the healthcare system. We also really want these other two legislative positions, which would be those against those mandating universal access and also against financial barriers. We also want to ensure that through system activation, there are things that can support access. And these really focus on toll-free universal access numbers that we wish to then develop and implement. And then what we want to also look at is we want to make sure that there's legal protection for pre-hospital providers in their own right, and also for bystanders who actually assist patients. And then we also want to make sure that there are regulations that can coordinate and ensure standard setting for private services. And then we have some of these other things that we need to put in place in order to ensure training, licensing, and credentialing, and so forth. So putting these four aspects then of an enabling governance structure in place would be really important for us to, as we start thinking in implementing the toolkit and actually moving forward in that way. Now, one of the key things, unfortunately, is that it isn't always possible for an emerging or a nascent system to implement the entire toolkit at once. This could be either because there might not be the financial or the human resources. It could be because there might not be political will. It could mean that it just is simply too complex to go all at once. So what we need to be able to do is we need to be able to find a way to transparently start triaging what tools we implement when. And to ensure that we can do this at scale and sustainably, given the constraints that we have in a particular emergency care system. And these trade-offs, unfortunately, are sometimes not made in a very transparent manner. And we don't always think about why these trade-offs are being made. But luckily, the WHO also has this evidence to decision framework, which is called the WHO Integrate Framework. And this framework really has a number of different elements that we need to think through when we are making a decision on what it is that we need to implement and how. So we have to think about these things at three different levels, which is what you sort of see in the core of the framework here. And we have to think about at the individual level, as in this patient in front of us or this provider in front of me. At the population level, so how do we think about distributing these resources to our entire nation, or maybe our one district or something like that. And then we also need to think through this at the systems level, thinking about it more. This is where we start comparing, whether we should be investing in emergency care systems development or whether we should be investing rather in surgical capacity, but oftentimes those could be the same things. So we have to think about how all of the different tensions in what we want to be investing our time and our funding into, how they can affect things at system level. And then we want to think about a number of criteria. There's 6 of them. For instance, a balance between harm and benefit. We want to talk about health equity, equality, and non-discrimination as an example. We need to think about feasibility of its implementation. How much will this cost? Can we even afford it? And then all of these things that we think about at 3 different levels and with 6 different criteria, we use quality of evidence in order to help us make that decision where the evidence is available. But as many of you might appreciate, especially in especially in low middle income country contexts, there is often an evidence vacuum that exists, which means that many times we either have to make decisions based on evidence that we extrapolate and try to contextualize into the context in which we're working in one way, or alternatively, we need to just make a decision based on what we think might be the good, the best decision in that moment. So the nice thing about WHO Integrates, and this is literally from 11 May 2026, if you go to this website, who-integrate.org, you will actually find a WHO Integrate framework sort of structure and questionnaire that can help you think through using this framework on what direction you really should be going in and where you want to be thinking about implementing and what would be the best option for you. So these tools are really available to help you make sense of what Lee spoke about earlier in terms of going through into the implementation space. The next thing to think about, now that we know how to set the enabling environment and we have that ready, and of course those wheels turn really, really slowly, right? The legislative wheels, but they are important to ensure that we are ready for these implementations. Then we go into thinking of using a value structure, which is then WHO Integrate, to be able to start prioritizing the different implementation tools in the toolkit that we might need to be thinking about. And then one of the important things is to use Pete to plan a roadmap into and how you're going to be implementing things. Because what Pete does is it actually forces you to, at the moment that you're recording a gap, to actually record why it exists. So you have to think through, as you are developing and moving through Pete and applying that to your service, whether that is at a station level or a base level, whether that is at a district level or whatever level you're wanting to actually execute it, you have to think through what those gaps are and what are the reasons for those gaps for existing. And by looking at this, you can actually you can match the gap plus the reason for the gap, apply the framework that you have from WHO Integrate, and then select the right elements of the pre-hospital toolkit that Lee spoke about earlier, and plot that into where you need to look at it, and in what order you might need to do it. By seeing, for instance, that one problem might be an issue with legislation or an issue with standardization in maybe equipment, as an example, you can then see that the reason for that is that because there isn't oversight, in which case you adopt the guidance by WHO, for instance, on what the medical direction should be doing. Is the issue not that there's no oversight, but that there's no standard? Then you take the standard that is published in the operational guidelines or guidance document, and then you can adapt it and implement it into your setting. Is the issue that you're not monitoring it properly? Then what you can do is you can take some of the suggested metrics that are in the WHO documents, and you can use that and implement that to benchmark against in your system. So PEAT then allows you to, and when you look at the report template, it gives you a good idea of how you will actually be able to develop that. And the nice thing, of course, is that PEAT gives us an actual step-by-step guide on how to implement this at whatever level you want to do it. So when you are starting PEAT or doing a PEAT assessment for the first time, you start with the PEAT tool on the one side of the table, and you have your guide on the other side of the table. And then you use that and cross-reference that using multiple different sources of information. You can ask a multitude of different people, and the types of people that you can ask which questions to is also contained in the PEAT user guide. And then you take your PEAT assessment, and then afterwards you use your template report, and you basically just populate it, and you have something that's actually really easily usable for you to then build the rest of your roadmap. So I want to just quickly give you a worked example of how you could use the gap and the barriers and the toolkits and the integrator appraisals in order to actually reach a particular policy decision. And one of the, or implementation decision, shall I say. And one of the things, of course, that you'll remember about WHO Integrate is that around WHO Integrate is also the need to assess evidence, right? So let's have an example here. So PEAT finds the gap. Then we look at what is the barrier or the issue that's a problem with it. Then we find the component of the toolkit that we can use, and then we use integrate in order to decide if this is a good idea or not. So let's say, for instance, PEAT item 2.11 says that there's no legislation protecting bystanders who assist the acutely ill or injured. So there's no bystander protection laws. The barrier here then to us actually providing emergency care in this instance would be that bystanders fear civil and criminal liability, police detention, and being billed for the patient's treatment. These are legitimate fears, and we know that these actually cause barriers to caregiving behavior. So then we know from the toolkit, well, there is the Community First Aid Responder Program, so we can implement that exactly. And then we also see that we can look at the governance framework to see how they can integrate into the rest of the system, right? And those things are available. If we look at integrate in particularly, we see that those places where the ambulance do not reach us are also the places where the bystanders are the only people who will be able to support it. And, we understand that it costs almost nothing. So from a WHO Integrate perspective, we know that, this is probably a good idea to invest in, right? And to move into implementation. When we look at the evidence, though, we see that 84% of people in India and 88% of people in Cameroon, for example, in two different studies, of course, were unaware that a protection law actually exists, and over half of protected bystanders were still detained, as an example, right? And this means that care-giving behavior is obviously curtailed. So when we put all of these things together by using these tools, what we see is that, yes, the intervention to implement community first aid responder programs is a good idea. It promotes equity, it is feasible, and it is cost effective. But because of how we see the evidence, we realize that when we are going to be implementing this, we need to do a couple of things simultaneously rather than one thing in isolation. And that would be to actually have the law in place, fund public awareness, particularly around the law, and train police into compliance with that law itself. And these things together will then ensure that it is potentially a sustainable and more effective implementation strategy than if you didn't use these different tools to help you support your implementation approach. Now, the last thing I then want to talk about is evidence itself. And we know then that there exists this evidence vacuum, as I've said previously. And when you are thinking about implementing any of the parts of the toolkit, think about measuring impact right from the beginning, so that it's not something that's just, an afterthought later on. Because what's helpful is if you think about measuring impact from the beginning, you set up your systems, your implementation systems in such a way that data collection for impact is a little bit more light touch. For example, what's helpful, for example, is in the toolkit, there's a standard ambulance patient chart that's included in the toolkit. And the patient chart includes a lot of the things already that would be used to monitor the impact and the performance of your implementation. Like, for instance, response time intervals, for instance, patients with severe pain receiving analgesia, patients with hypoxemia receiving oxygen. So if you then implement that data collection from the beginning, as well as the basic ambulance provider course as an example, then you can actually start monitoring those things routinely right from the initial outset, so that you do not have to go back later on, and maybe there won't be sufficient data available. In saying that, as Lee mentioned, and this was the draft, as you can see, the draft global strategy document that served at World Health Assembly 79 in May 2026. But now that's, of course, been passed, and that means that the WHO is required or has been mandated to develop this global action plan. And the idea is, and Lee can elaborate on this in a moment, but the idea, of course, is that the action that each of the different parts of the action plan will have a series of actions, of course, and each of these actions will have about 3 to 5 indicators and associated targets that member states will have to be reporting in order to demonstrate their progress towards the implementation of the action plan and improving emergency, critical, and operative care. Now, these particular indicators and targets have not been, they're in draft at the moment. I believe there's a couple of hundred of them at the moment. But a couple of colleagues from WHO and other experts around the world will convene this August, which is in basically 3 days' time, will convene in Norway at Utstein Kloster, and they will then be going through a consensus process where they will be developing these particular indicators as well as their targets through a consensus process. And then once that's developed, these will be ratified and will be released for us to then start using that to monitor our progress towards effective implementation of these resolutions and also in improving emergency, critical, and operative care. And many of these indicators will almost certainly be relevant to pre-hospital emergency care. So watch the space for that to happen. And then the eventual idea is that much like the global, the resolutions on road traffic safety, member states will be required to then submit these indicators, and then there will be these global status reports on emergency, critical, and operative care, so that we can see how the world is tracking towards progress and towards improving this. So this is an example of the global status report on road safety, and I'm looking forward to starting to see how we have these global status reports on emergency, critical, and operative care moving into the future.